It gives me great pleasure now to introduce the moderator of today's panel, Dr. Ellen Frank, who will introduce the panelists. This is actually Dr. Frank's third year of being our moderator. She's so kind to do this. Dr. Frank is one of the true luminaries in the field. She is the director of the Depression and Manic Depression Prevention Program at the Western Psychiatric Institute and Clinic of the University of Pittsburgh Medical Center and is an expert in mood disorders and their treatments. She serves on the Mood Disorders Work Group of the American Psychiatric Association Task Force on the DSM-5, was chair of the Food and Drug Administration Psychopharmacological Drugs Advisory Panel, is an honorary fellow of the American Psychiatric Association, and was elected to the National Academy of Sciences Institute of Medicine in 1999. It is with great pleasure that I ask Dr. Frank to come up, and she will introduce the panel.
So I want to begin by thanking Dusty and Joyce for the privilege of being here with you, because it is only when we hear your stories that we remember why we're still up at 2 o'clock in the morning writing a grant application or answering the phone at 3:30 in the morning, or spending hours listening to audio tapes of therapy sessions to be sure our clinicians are doing just what they're supposed to be doing. And it's your stories that drive us to do what we're doing, because it's hard work. And I know of no harder worker than my colleague Boris Birmaher. Boris, you can all read his biography. Boris comes to us by way of Chile and Jerusalem and New York, and finally we got him to Pittsburgh, where he has done really groundbreaking work in trying to understand how children move from an at-risk position to full-fledged disorder, and groundbreaking work in the treatment of adolescent bipolar disorder. There probably aren't 10 people in the world who know as much about the diagnosis and the treatment of this condition as Boris. But not only has he been a careful, diligent researcher, but he has been clinician to the world of child and adolescent mood and anxiety disorders. People come from all over the country to be seen in Boris's clinic, and I can tell you from the experience of many, many friends and colleagues that the care that Boris provides is nothing short of extraordinary. So it's my great pleasure to introduce Boris Birmaher, who's going to talk to us a little bit about the challenges of figuring out what's wrong with my child. Boris.
Hello, thank you, Ellen. Very nice. Mrs. Sang and Mr. Sang, thank you very much. It's an honor to be here, and an honor of your son. I'm very happy to be here. This is my first time, and I'm very impressed. Then I was asked very briefly, because we will have more time for the discussion, to present 1 or 2 cases of children with bipolar, only to give you an idea of what we are seeing. And I choose 2 real cases. I changed the names, of course, of one kid who is easy to diagnose, and another one is a kid more difficult to diagnose, where most of the controversy is diagnosing these kids correctly from early age that we are seeing in our clinics, and we have problems. And let me start with the first one. I didn't do this. This is the father of these kids, who is an engineer, and he has been tracking these kids since 2011. I began to see this kid around here, something like that. And then what the father is doing is scoring the kids from 0 to 10 10 is being extremely high, and 0 is super, super sad. And as you can see, this kid is completely normal. No problems at all ever in his life. And then without any major reason and doing very well at school, he began to feel depressed. Then he began to be very high. And this is when the family began to worry. What happened with him is that he began not to sleep 2-3 hours at night, going into the internet. He got in love. This kid here was 13. He got in love with a senior girl, and then he began to follow her at school, and of course she got scared, and they called the principal. And this kid went to the principal, and while waiting for the principal, the janitor there was cleaning the windows, and he said, "You don't know," and he began to clean the windows together with the janitor and teaching the janitor how to do the things. Then the kid was very active, and high energy, talkative, super happy, and then he improved and then got very depressed. He was like 2-3 weeks in the house, super sad, and wanted to hurt himself. And then suddenly, again, very high. Then he couldn't control the symptoms, and then the principal of the school requests that this kid will be kept at home. They were afraid of him. And then this is when he came to see me. When I saw this kid, he was completely normal. And we offered them treatment with medications. And this kid with medications did very well for long periods of time. And then, unfortunately, around here, they began to question the diagnosis of bipolar, which is normal. Listen, who wants to have any illness, not only bipolar, any illness? Then, and besides this, the grandmother of this kid is very into natural things. Then she called me, and she's in a nursing home. Then she invited me to have tea with her. And then I went, and she explained me why the grandson cannot be taking medications. And then they decided, because it's their right, to stop. As soon as they stopped, this kid began to have problems again. And he got very depressed. And then this kid began to be very high again. And then we have to treat him again with the same medications. Unfortunately, this time, he didn't respond to the small dose that I was giving him before. I have to go double. And he has been doing well since, up to now. And the kid is functioning like any kid. I have to meet with the principal and the teachers of school because they were afraid that when he will come back, that he is going to be dangerous. But actually, after talking many hours with the teachers and do education, as Mr. Sang was saying, a lot of education with the public, they admit, and the kid is functioning like any other kid. The problem, and we can discuss this more, this kid is responding very well to medications, but he increased too much weight. And as a result of increasing too much weight, he developed something that we call fatty liver. Basically, it's a lot of fat in the liver, and then the liver is not functioning well. Then you have to make a decision here. Do you continue with the same medication or switch to something else? And the family is very afraid to stop the medication because what happened before. Now, this kid was easy to diagnose. It was easy if you listen to the kid well and you hear the symptoms that he has when he gets very high and depressed. There is no doubt that he has bipolar disorder. But let me present you another case. This is an 8-year-old girl, and she was referred to our clinic that is called the Children and Adolescent Bipolar Services because chronic mood and behavior problems. This girl has severe irritability, temper tantrums, behavior problems since age 3. Since very early age, she began to have a lot of problems. And she has symptoms of ADHD. I put this in quotes because you will understand why. She has poor attention to details, she's careless, impulsive, easily distracted, disorganized, misplaced things, cannot sit still, and very impulsive. If you put all these symptoms together, she has ADHD. And she has been treated for ADHD for many years. The problem is she doesn't respond so well. She also is quite oppositional, defiant. And not only at home, but also at school. Then she doesn't listen to the adults, she's disobedient, argumentative, temper tantrums. She's the kind of girls that go to school and she's not feeling good, she will give the finger to the teacher. Then she has the symptoms of ADHD and ODD, And the mother began to talk a lot, that her mood is very chaotic. She said irritable, and then sometimes she's sad. And a psychiatrist was suggesting that what she has is this new disorder, disruptive mood dysregulation disorder. And she began to be treated with multiple medications and multiple therapies, you name it. She came stimulants, clonidine, various, something we call atypical antipsychotics like Abilify, Risperidone, etc. And she began also to have some weight problems and liver problems, antidepressants, and a doctor gave her lithium, not because they thought that she was bipolar, it's because they thought that they can control her temper tantrums, but they increased the lithium very quickly and then she got toxic. Then when we interviewed the mother, when she came to us, the mother said that she has these periods that she gets very silly, giddy, hyper, and talkative. As you can see, many of the symptoms overlap with the symptoms of ADHD. And the mother thinks that the symptoms were beyond what is expected for her age. They can occur at home, at school, and they can last 3 days up to 3 weeks. But it's usually 3-4 days that she gets extremely silly and giddy. And then the problem is she's only 8 years old, and this begins to happen since age 3. For us, it's completely normal to see a 5-6-year-old boy or girl being silly. Actually, if they don't get silly once in a while, I worry. Then we began to see this kid, and the mother began to push the idea, actually it was not my diagnosis, that maybe the girl is bipolar. The mother also said that sometimes, without any particular reason, up to 1 week, very short periods of time, she gets sad, with poor motivation, lack of concentration, and sometimes she talks about she wants to die, she wants to kill herself. On 2010, she was taken to a hospital because, again, defiance, irritability, aggression, temper outbursts, and suicidal ideation with a plan. Then what we decided when she came to our clinic was to begin, we don't know her, we asked the mother if we can stop all the medications and observe her. And then the mother said, I don't have a choice, she has been in so many treatments, anyway, she's not responding. Then it took me 8 months in order to be comfortable with the diagnosis. What we began to see is that the mother was completely right. When her mood is normal, all these symptoms I described you about ADHD and oppositional problems disappear. We began to follow her very closely at home with mood diaries and also with the teachers. The teachers actually of this girl are very good. And they keep calling us once a week to tell us what's going on. And definitely when this kid, when her mood is completely normal, she is not acting out, she concentrates, she does well with the kids, etc. But then, sometimes when she gets very silly or depressed, all the symptoms of ADHD come back and the oppositional behavior. Now, we diagnosed her as bipolar, and currently she's treated with therapy plus medications, and for the last, I would say, 1 year, she has been stable, completely stable. Okay, I think I have to stop here. We will have more time to discuss. Thank you.
So, our next speaker is someone who is new to me, someone whom I just had the pleasure of meeting in the last 2 days. Gisela Sandoval is, now I have to read, director of the Wright Adolescent Clinic here at Northwestern, and a real new entry into the world of childhood bipolar disorder. Educated at Harvard, she has an MD and a PhD from Harvard, and did her child and adolescent psychiatry in the Cornell-Columbia combined program. Her particular interest is how the environment in which the brain sits, and by that I mean what substances are being put into the system, the environment in which the child lives, and by that I mean the family, and the genetic inheritance of the child combine to produce or protect from the symptoms of mood disorders. So it's my pleasure now to introduce Gisela Sandoval, who's going to talk a little bit about those issues. Please join me in welcoming.
Thank you, Ellen, for the presentation. And thank you, Dusty and Joyce, for having me here. It's an honor to be here and for organizing everyone who's here for this cause and the kids. So I'm going to tell you today about Matt, his sister, his mom, and his dad. Matt's a really great kid. Very interesting kid when his sister decides he is also that. When I first met Matt, and he was about 14 years old, I said, "Why are you here?" And he's like, "Because my parents brought me here." When you ask him about his mood is fine. I have no problem. So I want to tell you a little bit about him first before we hear about other parts of him. He's a kid that likes to play video games, like most 14-year-olds. He also likes to play paintball, where they fight with other kids. And he also likes to play the piano. He writes songs. He wants to be a writer when he grows up, and he enjoys writing stories, poetry, and he's actually even finished a book. He's smart. He does very, very well in standardized tests, however, not in school, and he actually got accepted into a prestigious IB program. One thing that his father right away told me is, like, if you catch Matt in the middle of the night, he'll be playing the piano, watching a video, or movie, and he will be writing a paper simultaneously. And his sister confirms this, and it's quite a scene, they claim. Matt lives with his parents at the time of when we first started seeing him, and he really wants his family to be together. He loves his parents. He also loves his sister and really wants to be close to her. So in terms of his history, Matt's a psychiatrist when he was in about 5th grade for a lot of disruptive behavior, and he went to a therapist a few times, and not much came out of that. Now, one important thing about this family is that they had identified his sister as the one that had mental health issues. His sister's older, and she was actually our first patient. We see both siblings in the clinic. So he has no medical problems, had no developmental difficulties, basically normal life history. His sister, who was treated in the clinic, has mood disorder. She has dysthymia, and she also uses cannabis and ecstasy. Mother and father both have depression, one with anxiety and ADD also. They're both in treatment. He has a maternal uncle with Asperger's disorder, and who also has a lot of mood lability, and there's a possible diagnosis of bipolar there. He also has a paternal first cousin with autism. Now, during our treatment, the parents got divorced. There was a financial crisis. The parents became unemployed, and they lost their home, which meant the children lost their home. They started having joint custody. The sister could no longer tolerate the behavior Matt had, so they used the divorce and the joint custody arrangements to basically separate from each other. So what they did is they alternated houses. So when I first met a brother and a sister that had conflicts but were together, they are now living completely separate lives. They just switch over houses and then they're together. So I want to talk about that because it's the effect sometimes mental illness has that we don't think about, how it affects the sibling relationships, the parental relationships, and how it can break apart a family. Or in reverse, how the impact of all of those things can aggravate what is primary a mental illness. So mom describes Matt as being a very social child who was doing well in school and basically had no problems up until, I think it was 4th or 5th grade. Then what she started noticing is that he became less interested in things. He started to have worsening school performance. However, he's always done perfectly in standardized tests, over 90 percentile in all those tests. So they didn't really know what to do with that much. Then he began, as he's gotten older, to have almost daily episodes of anger, rage, crying, yelling, and sadness. Matt also has other factors. So this is a case unlike Boris, who after 8 months could sort of figure out what was going on. I've been seeing this patient for 2 years, and his sister for more than 2 years, and the whole family almost talk to them almost daily. And I'm not sure what he has. And part of what I want to talk about is what is irritability, and what do we do about it. And when it's not episodic, when the children at this age have such a difficulty expressing their moods, and it's hard to figure out, and there's such a chaotic environment, it's hard to figure out what is going on when. The one thing everybody agrees on is that the behavior Matt exhibits is intolerable. It's hard on everybody in the family, and they don't know what to do. On top of that, Matt really believes he's right about almost everything, and that what he believes is what everybody else should believe. He has also impulsivity, inattention, difficulty finishing any task, and more lately, as we've been giving him more vocabulary, he's been expressing more and more anxiety about school. Family also believes he has a lack of empathy, and that gets tossed around of unclear meaning. He does not like, and he will tell you about this, he does not like when anything in his environment changes or in his routine. There was a huge meltdown recently at school when his brother had to bring him a uniform, a uniform for one of his classes, and his sibling forgot, and he basically just lost it at school completely, because this was part of the day. Mondays, this is day, and when we had multiple family sessions, he could not move from the concept that this was the day that you bring me this, and every Monday this happened. He has difficulty forming friendships, and he does not have any close friends. He also has a lack of interest in romantic relationships. So many symptoms. He's been given lots of rating scales, so have the parents. We've been observing for 2 years. He has met almost criteria for all the disorders that you see above. He has been carrying a diagnosis of ADHD or ADD for a long time. We, of course, when we met, we tried a trial of stimulants. It didn't do much. And so right now, he's been very compliant with coming to sessions. We're working very hard on him learning how to express himself and express different moods. And we've also had hospitalizations where, so basically all the diagnoses not just come from our clinic. He's been hospitalized. He's had different partial programs and intensive outpatient programs. And every time he's been to one of these things, he comes back with a different diagnosis, with people wanting to give him different medication. We've decided to keep on observing him. Recently, his anxiety has been so bad about school that he's been avoiding school. So not the classic oppositional, not the classic episodic moods, however, ongoing low self-esteem, ongoing self-depreciation, ongoing negative feelings, and ongoing complete mood lability, where in your office or at school he goes from crying to being angry to rage to back to crying, and it can last the whole day. So one of the things that I wanted to bring up really quickly before I end here is that, it's often hard when you first meet a family to figure out who the patient is. In this case, we actually had 4 patients that we needed help, and it's very hard for a family who themselves need more support, like the parents in this case, to have gone through this. And it has been imperative that we also offered them support, and in the context of also incredible economic difficulties. He's now 16. He's finishing up 11th grade. I want to bring up another little side point here about safety. So Matt has had a lot of temper tantrums, and they're often directed at the person that takes care of him the most, which is his mother. And when I first met Matt, he was about 5'2", 100 pounds. Now Matt is up there. He's like 6 feet, about 145 pounds. And when he has a meltdown, it doesn't look, it looks the same, it sounds the same, but now your danger risk goes up. So we've had to work a lot on educating the parents, especially mom, that there might come a point and she's had to call 911, which is very, very hard for a parent to do. And this adds the fact that sister wants to really protect mom, and she has actually gotten in the middle of them when he's had one of these outbursts. He never does damaged property, but he has hit mom. And the other thing that I wanted to bring up is, for better or for worse, Matt wants to become a police officer. And so this is another issue that comes up with our work and some of our kids, of when they have such high levels of irritability and impulsivity and mood lability, and they want to go into areas that might not be best for them, society, and everybody else. So we've had, trying to come up with what's the best fit when someone has these symptoms. So I just want to end here by saying that I really believe that when you have so much irritability, and that's his primary symptom, in the context of so many other stressors, how important it is that we start looking at irritability and start studying what does irritability mean, and start doing longitudinal studies that can tell us what the symptom really means and where it's going to end up. And are these kids that only have this and have a little bit of everything else, are they going to end up being bipolar? Are they going to end up just being unipolar depressed? Or are they going to be okay? Because if we know that, if we can have studies that are evidence-based on what happens based on different biomarkers, different cognitive testing, different MRI results, then I'd be able to right now maybe do some preventive treatment, then be more aggressive in my treatment pharmacologically, in my psychosocial intervention than I am able to right now. So, thank you.
Thank you. Maybe you want to take my seat so you don't have to wander back up here. So for those of you who are returning guests to this medical briefing luncheon, you'll be not surprised that we have a returning speaker, Dr. Janice Wozniak, who is at the Massachusetts General Hospital and an assistant professor of psychiatry at the Harvard Medical School, has now for the third time, or the fourth, come to this medical briefing luncheon. And Janet has something very special to talk to us about today. Being in Boston and caring for vulnerable children, she, like many clinicians in Boston, was deeply affected by the trauma associated with the bombing at the Boston Marathon. And I don't know exactly what Janet is going to say, but I suspect that she'll be touching on the theme that children who are already vulnerable by virtue of their psychiatric illness, and particularly children with bipolar disorder, who appear to experience whatever they experience so much more intensely than the average child, are especially vulnerable in the context of trauma. So Janet, please tell us about the last couple of weeks.
Well, that was a good summary, I would say, Ellen, of my punchline. So in that setting, let me tell you a little bit about what it's like to have been in Boston recently, and also some of my thoughts over time that I've had about the effects of trauma on development in children who, with or without problems from the get-go. I mean, and you don't need a Harvard professor to tell you that trauma or difficult life experiences can have a profound effect on mental health. Any of us who have gone through even all of the typical bumps in the road that life brings us, we all know how much that can upset your emotional mental state. But maybe the few minutes that I have with you today will lead us all to consider some questions which the field is grappling with, which I grapple with, and I'm afraid I'll probably leave you with more questions than answers. But to start with, it's not unusual to think that trauma could lead to difficulties in emotional regulation. Surprisingly, there have been very few studies looking at the role of trauma in the unfolding of bipolar disorder in children. Boris has actually been an author of one of the very few papers that demonstrated that there are high rates of trauma histories in the children who come through his clinic with pediatric onset bipolar disorder, 1 in 5. and not just with small traumatic experiences, but major histories of sexual and physical abuse. So we know that this is a really significant area of concern and overlap. But we don't really know why some people may be more severely affected by trauma and some might be less affected or more resilient in the face of traumatic experiences. We know that the outcome of trauma for most individuals, and then trauma is widely defined in the scientific literature, from abuse and neglect all the way to having experienced a car accident or a bus accident, or probably there'll be papers written about the people who have went through the Boston Marathon incident as well. But most people who go through significant, extraordinary traumas don't come away from it with what people call PTSD, post-traumatic stress disorder, which you may see in the movies and such as having intrusive recollections and flashbacks. We think of people who go through war experiences as having that type of re-experiencing of the event in such a dramatic way, which is called post-traumatic stress disorder. Most people who go through difficult traumas, even extraordinary ones like war, come away with worsening and severe depression and anxiety symptoms. This question of how often trauma and what sorts of traumas lead to bipolar disorder, we're not certain of. But we do know, as Ellen pointed out, that some people may be more vulnerable to the adverse effects of trauma than others. And so just 16 days ago, we had this extraordinary event in Boston, which jarred everybody, in every kind of level of contact, from the furthest away to being right there at the finish line. Part of what we did in our child and adolescent service was we were called upon to give advice to families. How can we talk to our young children about this event that just happened in our hometown? And I have to say we were all had to take a deep breath and think about how to even answer that. The best answer came from, I think, one of my colleagues who said that what we need to do is to tell children that there are more good people in the world than there are bad people, and that there are more people who really want to help others than there are people who want to hurt anyone. And certainly being in an event today brings that message closely to the heart, and is one of the ways in which I think we've all gotten through this event. To be in the midst of some awful event like the one in Boston is to have seen the best of humanity and human spirit. And I see that in an event like this today too. We did some work on trauma many years ago, and it led us to ask a question, and that Boris raised in his paper too, which is how can we understand the causality of things? It's when you see a child who has severe mood dysregulation, bipolar disorder, and they have a history of trauma, the simple idea would be to say, oh, they experienced something awful and that led them to have these terrible symptoms of bipolar disorder. So indeed, trauma could probably produce bipolar disorder in some individuals. I think that there's no doubt, even in somebody who otherwise, to seem well-adjusted, a terrible traumatic event can bring about severe emotional dysregulation. But another question that we asked about is, could bipolar disorder predispose to trauma? And you might wonder how that could be so. And I'm not suggesting a trauma like the Boston Marathon, but what I mean by that is that if a child has bipolar disorder, he may have relatives with bipolar disorder who could be reckless or emotionally erratic, rageful, disinhibited, or even at the very least, poor supervisors of that child. Children or teenagers with bipolar disorder often put themselves in harm's way. They have sexualized behaviors. They may be disinhibited and seeking out strangers. Sometimes often they're open to novelty, which may mean dangerous stunts. They sometimes act in such provocative ways that they inspire rage of the people around them. And I've certainly met children who I've said to their parents, I think your child might drive Gandhi into a rage of a fury over their actions and activity. So children with bipolar disorder may be more vulnerable to trauma. And when I see children with bipolar disorder who don't have a history of trauma, one of the things I warn the parents of and the child is to be careful that that doesn't occur to further complicate the situation. And I've had plenty of young women under my care who, when they hit adolescence, all of a sudden had to add date rape and sexual traumatization to their list of problems because they weren't thinking. They were feeling lucky, they took a chance, and they were overly trusting of someone. So although it seems odd to think about it, bipolar disorder could predisposed to being traumatized. And then you go to this next problem with, because you have bipolar disorder, those children will be more adversely affected by the trauma than children who don't have it. It's as if the bipolar disorder poses a risk factor for the sequelae. The same way that you might say people who smoke cigarettes are at a greater risk for developing lung cancer. Not everyone who smokes gets lung cancer. There must be some predisposition for those in which the combination is particularly concerning. This is a picture I found on the internet, one of the many that was taken during the bombing, and I don't know these girls at all, but I thought the picture was an important one to illustrate a few points. First of all, any of these girls, especially the girls with the more eccentric styling, could be one of my patients in our bipolar clinic. And I meant to choose it because I wanted to illustrate that there are different reactions to an event. And you might say that this is an illustration of someone who's taking it very hard and two people who are not, but it may be more difficult to even figure out than that. Sometimes an appropriate display of emotion is actually the best way to cope so that you don't have the longer term sequelae of the problem or the trauma. So it's important to think about how people cope and get by after an event. And the other thing I liked about the picture was the camaraderie. And it illustrates that after there's been a traumatic event, that one of the best things that we can do is to be together, to talk about it, to support each other in whatever emotional recollections that we may have. The other advice that we recommended to parents of children in the Boston area was to be with your children, to hug them, to have more family time and family dinners, to ask everyone what had they seen and what had they heard. Because these traumatic experiences, being in it is one piece of the trauma. But hearing it and hearing the stories and seeing the news coverage, well, that's all quite traumatic in and of itself. In talking about this today, I actually had a worry that I might traumatize everybody in the audience if I were to tell some of the more sad and miserable tales that we are learning about in Boston as people recover from their injuries and sort through their recollections. Well, so in this setting, let me tell you about this girl named Lucy, who, by the way, also has some eccentric styling, like the girls in the photos. She likes tattoos. And where's Dusty? She likes tattoos, who we were talking about this. She has one on her chest that she got in some peak of, I don't know what she was thinking, but it says, "Trust no one." And then the one on her back says, "Love the one you're with." So in and of itself, she's a kind of a walking illustration of the complex reactions and feelings that she has in her life. Well, she's been under my care since she was about 6, so I always see her and wonder if she's got a new tattoo these days or what else has changed. When I first met her, she was one of these girls who came in and would sing show tunes in the waiting room for me and for everyone. Everybody would smile. My cheeks would hurt when I was with her because I would just smile so much because she was so bubbly and energetic and absolutely adorable. Was that her main problem? Well, no. That was actually pretty adorable and seemed to actually be a positive in her life. Her problem was that she was having these rages. Her mother would call her feral, that she'd get into this state where it wasn't her, she couldn't reach her. There was a look in her eyes, and it was like she was a bundle of impulses. But as often happens with bipolar disorder, and I was seeing Boris's slide of that father who illustrated the mania and the depression, people with bipolar disorder often end up spending more time with debilitating depression than they do with manic level symptoms. And it's a real problem for us in our treatment programs because we don't have great treatments. We have lots of antidepressants, but bipolar depression is a different problem and very difficult to treat. But be that as it may, over the years, I've had her stabilized on, there you see them, 1, 2, 3, 4, 5 medications. Do I love giving someone 5 medicines? No. But has it been the only way to help her function and be at her best? Well, yes. So there it is. 5 medicines, and each one does something a little different. One's more for her depression, one's more for the mania, others are for her anxiety, which is significant, and the other is Concerta is a medicine that we use, methylphenidate ER, for attention and focus, because she's actually a brilliant girl, and doing well at school is one of the things that buoys her self-esteem. But so let me tell you what happened to her. She wasn't at the finish line. She was at a Red Sox game, which is, I don't know, a few miles away. And the Red Sox game was getting out around the time that these bombings happened. She was on a subway train that got evacuated. They didn't move. And then everybody was grumbling and complaining, how inconvenienced, how terrible this was. It took them 5 hours to get out of Boston and get back home on a series of buses. And during that time, the bits and pieces of the story from down the road were unfolding. So she was hearing the stories and hearing the tales, second, third hand. But to talk to her, when I talked to her on the phone, she said to me, I was there. And her emotion and her intensity, I really thought she was right there at the finish line. She was close enough. It's made a dramatic impact on her mental health. So over the past 16 days, I've been coping with talking to her about this severe depression she's in. It's one of the worst I've ever seen for her. She can't leave the house. She's crying spontaneously. She's hopeless. She's taking it so terribly hard. It triggered one of her terrible depressions. Has she ever had a depression like this before? Yeah, she has. Maybe not quite this severe. She's had depressions that arose spontaneously. But this one, the cause and effect was obvious to me, that this event led to this reaction. Well, I look forward to taking your questions at the end. Thank you.
So our final formal presentation is going to be made by Mary Ellen McGrath. And those of you who have been part of the Ryan Licht Sound Foundation efforts will know her well. A world-class corporate attorney, in addition to managing a very, very demanding career. Mary Ellen has been the brave and remarkable parent of twin daughters, one of whom has bipolar disorder. And she's going to tell us just a little bit about her experiences as mother of those two daughters, and then we will take your questions. Mary Ellen.
Thank you for that nice introduction. So Joyce asked me to tell you what it's like to be the parent of a child with bipolar disorder. And as anyone in this room who has a bipolar family member knows, it is many things. Quite often it is exhausting, infuriating, and heartbreaking. Other times it can be oddly inspiring and definitely bittersweet. My daughter is 11 and a half years old. She's blonde and beautiful. She's sweet. She loves theater and music and the color pink. She dreams of being a movie star. She longs to be popular. She loves fashion and accessories. And she was diagnosed at 7 with early-onset bipolar disorder. She's also a twin, not identical. Her sister is not only typical, she's exceptional. A gifted student and athlete, well-liked by her peers. She's an all-around great kid. Her twin is alternatively embarrassed and angered by her sister. Yet she's fiercely protective of and endlessly worried about her at the same time. The girls are also children of divorce. Their father and I separated when they were 5. 2 years before the diagnosis. Our divorce has not been amicable. This has been hard on both girls, and particularly on my sweet girl who struggles with bipolar. Her issues presented when she was not quite 2 years old. My sister Sheila, who's a social worker and is here today, identified some developmental delay, which led to basic therapy. That addressed her speech and motor issues. But her increasingly volatile moods, however, remain a growing source of frustration and difficulty for our entire family. By the time she was in kindergarten, she would have periodic meltdowns, which over time became more frequent and intense. It became harder and harder to calm her after extended periods of time, often for over an hour. This was in stark contrast to her sister, who would get upset over things, but eventually self-soothe, or was able to be calmed without extraordinary time and effort. We went for a psychological exam and were then referred to our wonderful psychiatrist, who diagnosed her in one visit by saying, "I see a lot of kids with bipolar disorder. Not only is she bipolar, she's really bipolar." I remember feeling like I'd been hit by a freight train. Bipolar was such a terrifying word to me, and I was in such a state of shock that it was being applied to my sweet girl. But I knew she needed help, so she started on medication immediately. And miraculously, she got better. Her mood stabilized, she had periods of contentment, and life in her house became calm. But as my mother, who is also here today, has a great expression, everything is always changing. And so is my sweet girl. After a while, the original medication, which had rescued our family, eventually started to lose its effectiveness. So we had to add medications and change dosages. I started a notebook to keep track of everything. As she grows and her body changes, her treatment has become as much art as it is science. And always there is lots and lots of therapy. All of this is extremely frustrating and exhausting, most of all for her. She longs to just be like every other sixth grader. So on most days, we walk on eggshells, knowing that whether it's a good day or a bad one depends largely on her mood. The smallest thing can send her into orbit: a lost earring, a broken zipper, or her sister chewing cereal too loudly. We, the family members, are required to be superhuman in our patience and tolerance. My heart breaks on a regular basis, as the world is not an easy place for her to navigate. School, friends, emotions, simple situations, all of these are so hard for her. It's also hard on her twin, who just wants a sister who's normal. Speaking of which, bipolar disorder presents unique challenges for the parents and siblings. Because the bipolar child's needs are so great, he or she consumes a disproportionate amount of parental attention. This can leave the other siblings feeling neglected, resentful, and unhappy. They may act out to gain attention, withdraw, or even worse, become depressed themselves. The parents, who are already exhausted from dealing with the bipolar child, are often running on empty, with little left for other family members. I'm a single mom, so I put out the fires with my special one, and then try to muster up as much energy and empathy as I can for her twin. Some days I do better than others. I usually end up tucking in the twin at night and talking about what was difficult that day. I try to make sure she feels heard and validate what she's feeling. She often asks when her sister will be better or cured. Those conversations make my heart ache, for her and for her sister. So I have many worries. I worry about my sweet girl surviving middle school and then high school, and how puberty will affect her condition. I worry whether she'll go away to college, live independently, fall in love, and make friends who will be patient and understanding. Her family has to tolerate and love her and tolerate those meltdowns, but other people don't. I worry about her twin and her emotional state, as she so often has to suck it up and be the good, responsible child. And I worry about losing my own mind, as both girls love to save the drama for their mama. In the end, I get a lot of inspiration from my sweet girl, who has so many challenges and yet faces each day with a smile, a positive attitude, and a hot pink outfit with accessories. I'm also inspired by her twin, who has developed incredible resilience, strength, and compassion because of our family experience. I don't know what the future holds, and I don't have any answers to coping as a parent in this situation. I lean on a lot of people, many of whom are in this room, and all of whom I'm grateful for. And I basically take it a day at a time. I'm grateful to Joyce and to Dusty for allowing me to share my story with you, and for their tireless efforts on behalf of all our families. Thank you.
Thank you so much, Mary Ellen. Now, if our panelists will join me up here on the podium, and who's collecting the questions? Okay, so please, if you have a question or a comment that you would like to share, please raise your hand and someone will come and find you with the microphone. Yes, in the back there.
Hi, can you hear me? Okay. Somebody commented on careers, and this might sound like a really strange question, but I know because of the instability that a lot of times people with bipolar, as they get older, have a difficult time keeping a job. So what do you do with the kids to try and get them into something where they might be successful if they're, you know, struggling with this on a daily basis?
Go ahead,
I see, yeah. So I guess there's what I would say a lot of inter-individual variation to thinking about even getting through school and then thinking about careers. Most of the young adults who I see with bipolar disorder, I would say, who find themselves in gratifying careers, have worked themselves into something that has a lot of flexibility in terms of hours or days. An example recently is a young woman, brilliant person, got a master's degree, tried to have some conventional jobs in companies like in human resource, but it was too difficult, you know, and she'd have a few bad days and take time off from work. It was very upsetting to the workplace, and she'd get negative feedback for it. She's working now with a friend who has her own mortgage company, and it's actually perfect fit for her because when she's on, and she's busy, and she connects, and she makes calls, and she connects with the clients, and when she's not able to, she steps back and she can take a break. So I think that flexibility, which is in short supply in many professions, is something that I think all of us could benefit from, but people who are battling bipolar disorder particularly benefit from careers that have that built into it.
Other thoughts, other comments?
Only to give you hope for the ones who have kids with bipolar. We recently decided to analyze a large data that we have. We have a study that is done in Pittsburgh, Brown University, and UCLA, and we have been following them almost for 12 years. And it's around more than 500 children and adolescents with diagnosis of bipolar. And usually we concentrate on the people who are doing poorly. We decided to do exactly the opposite. Let's concentrate on the kids who are doing well. Why we decided to do this is because we began to, following this kids all these years, we began to see a group of kids who are not taking even medications and they're doing well. And we began to even ask ourselves, maybe the diagnosis was not correct. Maybe what we call bipolar, they were not bipolar, and now they're 25, 26, 27, and doing well. Then anyway, we did the analysis. And then we haven't published this yet, and we are in the process to analyze this, but only to be brief, there is a group of kids who, the study the analysis was almost 8 years of follow-up. Then there is a group of kids who are doing almost 80% of the following time doing well. And when I say it's mainly the mood symptoms, the depression, mania, hypomania, then they're doing well. There is like 30% of the kids. There is another 30% of the kids doing poorly, persistently poorly. It's like they're doing well because we concentrate on the well. They are doing well only like 20% of the following time. There is a group in the middle, and there is a group who start bad and then improve. Then if I put all the kids who are doing well at the end of the study, it's about 50% of the kids who are doing well. after 8 years of follow-up, then it means that there is a good group of kids, and I cannot call them kids anymore because they're like 25, 26, who for whatever reasons they are doing quite well. Then we are analyzing now the factors, like clinical factors, demographics, the parents, the kids, the families, treatments, etc., that can explain this, why a group of kids is doing so well and another group of kids is not doing so well. Because if we find out the characteristics of these kids, maybe we can use them for treatment in order to foster these characteristics in the kids who are not doing so well.
So Gisela, do you have something to add to this about occupational future for children with early-onset bipolar disorder?
I think I would agree with what Janet's saying about flexibility. I think that comes for bipolar and mood disorders in general, that there needs to be some flexibility and some space where someone can be, I'm not feeling that great today, so I'm just going to tune out and be in a little place where no one will notice until I feel a little better. And I mean, that's true for someone who has other medical illnesses where they might have suddenly, a sugar low and they might need to go lie down and have some orange juice, and we need to permit that. I think our society needs to be more adaptable to the fact that everyone can, contribute to society without having a perfect health, perfect health. So I think for me, in the ideal world, as we move forward, we should create jobs and create professions in which that allows for people to have what I call timeouts, just like the way some of my kids who are younger, some of my patients, if I talk with teachers and I say, when they're not doing well, let me have them have a timeout and come back to the class without any negative consequences, the kids do much better. I think adults, as they get older, need that too.
So I would just add one thing from my own experience treating young adults with bipolar disorder, and that is flexibility, absolutely, but also very specific routine seems to be extremely helpful. So being a policeman who may have to work 7 to 3 one day and 3 to 11 the next day and through the night the next day, not a really good idea. But positions that have a very specific routine, and probably for many patients with young people with bipolar disorder, a routine that doesn't require that they be at work at 7:30 in the morning. Because there is a very strong tendency among individuals with bipolar disorder to be what we call phase delayed. That is, to have a strong preference for a later bedtime and a later wake time. And young people who can find jobs that work with that natural tendency of their body to be delayed relative to the rest of the population in terms of their sleep-wake seem to fare much better. So that's just a comment from the perspective of someone who works with young adults with bipolar disorder. So another question, another comment? Yes, please.
My daughter's 22, and she was just recently diagnosed, and the last 10 years I've called it we've had sort of the fire drill, because there was always some more pressing issue going on. First it was drugs, then it was eating disorder, and so everyone always wants to address that piece versus finding out other issues. Now that she's diagnosed, they're having difficulty in dealing with multiple things at the same time. How do you typically deal with multiple diagnosis, I guess?
But I think you have to deal with all of them, and then one at a time, because the problem is if you have bipolar plus use of drugs, it complicates everything. Then most of these drugs can completely destabilize the mood. Then we usually tell the kids that if they continue to use drugs, don't expect us to help with their mood, because the drugs are going to put their mood up and down all the place, and the medications don't work exactly the same. Even the psychotherapy doesn't work. Then we have to deal with all the issues. Then if it's abuse of drugs, this is the thing that I do sometimes, and Sometimes I have to admit the person into the hospital in order to be sure that he or she is not taking drugs, because otherwise it's not going to work. Then if there are other disorders like anxiety, and anxiety is very common with bipolar disorder, then you also have to manage anxiety, and also you have the bipolar. Then you're managing 3 or 4 things at the same time, and you have to juggle with the medications and the therapy, etc. Because sometimes even the medications for one disorder make the bipolar worse. Then you have to be very careful in choosing the medications and doing things for them.
Gisela, do you want to add something
I
about
wanted
these
to just
complex
comment
comorbid
on
cases?
comment on my case. So I have to get Matt to school. Otherwise, he's failing school. So, but at the same time, his mood is all over the place, and he's having outbursts everywhere. At the same time, he can't pay attention, and at the same time, he's too afraid and avoidant because of his anxiety to get to school. So, I mean, I have to deal with all of them simultaneously, so he functions. So we started attacking the anxiety pretty early on to get him to school. That still hasn't worked. And so it's interesting how, and then as Boris just said, the medication for the anxiety is not helping too much with the outburst. And then when we had him on stimulants, that wasn't helping too much with anything really. So you really just try to, we sometimes just sit together and come up with a plan for the next week with the parents. Every week we come up like, this is what we're going to try this week. And it's almost like case by case, day by day, on how do we address all of them. Because if I can't even get him to school, how can I ever get him to do anything else?
Mm-hmm. Janet, do you want to add anything there?
Yeah, I mean, I guess to validate your experience, it does feel for clinicians like us that this is a moving target. And especially in children and adolescents who by their very nature are unfolding in their identity and personality, the symptoms are also unfolding there in front of our eyes, and what we see one visit may be different from the next. But I guess part of being a good diagnostician, and what we try to teach to all of our trainees, is to not just be the blind man with one part of the elephant, but to make sure that whatever problem you see in front is also, that a full assessment is done to make sure that you have the full sense of all of the issues. Then you're in a much better situation to do triage. So if someone has an addiction and you're dealing with their addiction, it's helpful to know that it might be fueled by episodes of mania and depression, so that they can battle their addiction. If someone has an eating disorder, it's helpful to know that depression is, or anxiety might be fueling the symptoms, self-consciousness or body image. It doesn't necessarily mean that it leads to a clear paved path of how the treatment occurs, but at that point you can use your team of clinicians to triage at any moment what needs to be the top priority, whether it be getting all the team to get the kids to school, whether it be using the medications to address the periodic elements of mania, and if you don't address that, you'll never be able to get the depression or the anxiety pharmacologically. It all starts, I think, with a good diagnostic picture of all of it, rather than letting chasing after the symptoms as they just occur to you.
Other questions from, yes, please.
Here, I'll just, thank you. I have a question. My niece has just recently been diagnosed with partial bipolar, and after listening to everybody, I'm like, yep, that's what she's got, all right. And her parents are like, everything she does, she just wants attention, she wants attention, she wants attention. And I'm always like, well, give it to her. But my question is, what kind of attention does she want? Does she want us to be mad at her? Does she want us to be loving to her? Because she's doing so many different things, and I'm not really sure what she wants from us. Because I think we're all doing whatever we think is appropriate at the time, but nothing is quite right.
Right. Maybe I can say something a little bit about that. I think that whenever you see a complicated symptom picture, it's a natural tendency to want to look for the cause. Why? What's the reason? And so I'll ask parents things like, does your child sometimes have outbursts? And they'll say, well, it depends. It depends on the situation, or sometimes because of this, or they do it for this. And then I usually stop and I say, let's put aside the whys, because we're speculating. You're speculating that it's why because she wants attention. We don't know that. We'd like to know why. But the start is just with the clinical picture. What symptoms are there? And then from that, we lead to our diagnosis and our treatment plan. And so I think it's important to be humble about the whys, because it may not have much rhyme or reason. It may not necessarily be a question of attention, although that's clearly what happens in the midst of it all, and sometimes can take on another meaning for everybody involved. But first and foremost, I think it's important to recognize that the sad fact, and I hate to deliver the messages, sometimes there's no good reason. Sometimes it just happens, like any illness might happen. Why does one person get cancer and another not? Why does someone have a heart attack even if they've lived a healthy life and don't eat cholesterol? It may have to do with some underlying vulnerability, and that's what happened. The brain is structured and functioned in that way, and so there's the symptoms. Triggers are a different question, and triggers can lead to treatments. What may have triggered it? Do traumatic events trigger it? Does contact with certain people? Does being overwhelmed by situations at school? Triggers you can work with, but I think it is a tendency and a wish to have a why, and may not always be fruitful.
So Mary Ellen, I have a question for you, and that is, if you had to name one thing that has helped you to cope with everything you've had to cope with over the last, 6 years? What would you say is the one thing that's been most important to you in terms of your coping?
That's a hard question.
You can have two things.
I can have two things? My family. My family has been just amazing, because as I try to parent, I need a lot of support. And so my family and my good friends have been a great source of stability for me. And I have to say, our team, we have built this amazing treatment team. So, it's the people around us.
Well, thank you for sharing those little bits of wisdom. And thanks to all of you for being here with us today. I think some of the doctors are able to stay for a little bit of time, so if you have additional questions, we'll be here for a little while. But we do want to be respectful of your time. So I think I speak for Dusty and Joyce when I thank you all for your presence here today and for your generosity in supporting the Ryan Licht Foundation.